Well, good morning. My name is Melvin Foote, and I'm the president and CEO of the Constituency for Africa. I want to thank you all for joining us this morning. This is the fifth and final program as part of the 2020 Ronald H. Brown African Affairs series, and we're real pleased with the series. And we thought we ought to close with a conversation about the status of COVID-19 in Africa and what is Africa's response to the crisis. So I'm really pleased to have my good friend, Dr. John Nkingasong, who is the director of the Africa Center for Disease Control in Addis Ababa, to share with us. I mean, he is the person most knowledgeable about what's going on with COVID-19 and what is the response that African countries and African people are making on the ground in Africa, and also what is the role that we as diaspora, those of us who don't live on the continent, what are our role to respond and to assist Africa in this regard. So without further ado, I want to turn the program over to Dr. John Nkingasong, the director of the Africa Center for Disease Control and Prevention. John.
Thank you, Mel, for the kind introduction and for your constant support. I mean, all through this very unprecedented crisis, and it has been a pleasure working with you and others from Harvard. So in the next couple of minutes, I would do three things. Just give you an update of where we are in Africa with respect to the epidemiological situation of COVID-19, and then continue to update you on what Africa CDC's response has been to the pandemic, and then conclude with some leadership strategies and challenges that the continent has faced, or some what are characterized as the silver lining for the continent. So first of all, the epidemiological update. As of today, September 18, is 9:00 a.m. East African time, over 1.3 million Africans have been reported to have been infected with COVID-19. Of that number, 1.3 million have actually recovered, representing a recovery rate of 82%. Unfortunately, 33,000 people have died. Our case fatality rate for the continent is 2.4%. Now, on this, I really like to emphasize that, as in most cases, when the first few people died of a disease in public health, there's sympathy, and there's also it's also a disaster and it's devastating. But as large number of people begin to be recorded as dead, I think they become statistics. We have to guard against this and know that we are here with COVID-19 for the long haul, and 33,000 people dying in Africa is a serious disaster, and we should always match these numbers to their life lost, and not just put statistics there. That is also true for the global picture of the almost 30 million people that have been infected, with 1 million deaths all over the world. I think that is a disaster for humanity. If you look at the trends across the five geographic regions of the continent in Africa, you see an encouraging trend. The Southern Africa, East Africa, and West Africa region have reported or continue to report decreases of new cases over the last 4 weeks. That is very good news. That is from the period between 10 August to September. If you can just move the pictures away. And so that is very encouraging news. If you look at the Central Africa and North Africa, the slides on the bottom part of this screen, they're showing some slight increases over the last 4 weeks. So overall, we've recorded a consistent decrease as a continent of about 10% over the last 4 weeks. And a lot of these, if you look at the Southern Africa, let me just go back on the top panel, top left-hand side of the panels, which shows minus 17%. A lot of that is driven by the lowering of the cases we are observing in South Africa. So I think South Africa has done a remarkable job in bringing down the pandemic, and now they are at the point that they are actually easing a lot of the lockdown and bringing the country to a lot of normality. I think that's very good news. If you look at the countries now a little bit in detail, so if you move from the regions to the countries, you observe that 26 countries are still reporting less than 5,000 cases of COVID-19. 11 are reporting between 5,000 to 10,000. 13 countries between 10,000 to 50,000, and 4 countries between 50 to 500,000. The last country there, of course, is South Africa, which accounts for for close to 50% of all the infections on the continent. If we now look at how our pandemic has shifted since the last time we had this dialogue, it took us 133 days to go from the very first few cases introduced on the continent on February 14 in Egypt to get to 500,000 cases. But as it is characteristics of this virus, it will only take about 36 days to get from 500,000 to 1 million cases there. So in terms of testing, I mean, there's been, of course, a big concern that testing was a big challenge on the continent. And very early on, when we had this dialogue, if you recall, we were all raising an alarm and screaming for more tests to be introduced on the continent. I actually wrote a piece, a personal view in Nature, saying let Africa into market for HIV COVID diagnostics. And in order to address that challenge, we launched a campaign called Partnership Against COVID Testing in April, and in June, precisely June 4th, we rolled that out. And since then, I'm pleased to announce that we have now conducted close to 14 million tests, representing a case ratio of 10 tests per case ratio with a 10% positivity rate. That is what, I mean, shows a remarkable progress that over the short period, we've actually gained a lot of momentum. If you now look at you unpack that a little bit and you look at the different countries and stratify them, you notice that 23 countries are conducting about less than 5,000 tests per million. So this is per million. And 13 countries are conducting about 5 to 10,000 tests per million, and 11 countries are conducting between 10 to 50 million per million. So there's variation across the continent. If you look at it, if you do a deep dive and to see where the testing needs are, you can very clearly notice that there's about 23 countries that need to improve their testing to catch up to where we are. As a continent, our goal is to make sure that we expand testing and be conducting about 1% of our population every month. That will represent about 12 to 13 million tests every month. The question has always been posed as to why the pandemic has taken the shape it has taken in Africa, with relatively fewer cases than other parts of the world. I think there are 2 explanations to that. First is that the country, as a continent, we took very drastic measures early on, even though they were extremely detrimental to the economy. If you look at this map, it shows the evolution of the measures we took. In March, there was no measure in place. I mean, the COVID-19 cases started showing up on the continent towards the end of February, that is beginning March. Then in April, as countries started recording their first cases, you can see that in orange that countries went into stay-home recommendation. and then others were actually implementing a strict requirement to stay home. So they're moving from recommendations to requirements. There is strict lockdown. If you look at the map in May, it gives you that picture that almost the vast majority of the continent had implemented strict stay-home or lockdown measures. And in June, of course, some countries started easing. I mean, like South Africa, and you know what happened in South Africa. They went through quickly. They were decreasing their bending the curve, and then they quickly went back to where they were. And as now we speak, more countries are easing the lockdown, and movement is beginning to happen on the continent. The second thing is really the age factor. And there's no doubt that the 82% of the recovery and also the large number of asymptomatic on the continent is largely due to the youthfulness of the population. There are so many young people on the continent. If you recall, 60 to 70% of the population is less than 30 years old. So let me now shift gears and discuss the response from Africa CDC. First, as I indicated earlier, I would not dwell into this because I did present this the last time we spoke. Immediately, the first cases of COVID-19 were reported in Egypt. The African Union Commission and Africa CDC convened a meeting, an emergency meeting of ministers of health, where we agreed for the need to coordinate our efforts across all member states, work with WHO and other partners to ensure synergy and minimize duplication. We also agreed that as a part of the joint continental strategy, we will promote evidence-based health practices for using science to inform prevention, diagnosis, and treatment to control COVID-19. And the three pillars of the goals of the strategy are indicated here. Our first goal was to limit transmission, and the second goal was to limit deaths or prevent deaths, and lastly, to prevent harm and social harm and economic harm, including the impact that COVID was going to have on HIV, TB, and malaria, and other immunization programs on the continent. And this slide just shows you a task force that was put in place to support these activities. The different technical working groups are included here. The underpinning principle was simple, that we needed to coordinate, to cooperate, to collaborate, and to communicate our efforts using the different task force that you see in the middle. And this task force, they cut across the continent from south to north to east and west, from member states, the WHO and Africa CDC and the African Union coordinating that. These are some products from this coordination. We've produced over 30 guidance on surveillance, in laboratory infection control, case management, and more in several African Union languages. We launched the PACT initiative, which is the Partnership to Accelerate COVID Testing, which was aimed to scale up testing to about 10 million. Recall at that time, the continent had conducted less than 300,000 tests, a continent of 1.2 billion people. Now, we've now exceeded that target and now set a new target of a new goal of testing 20 million individuals by the end of October. And some of the other PACT goals are indicated here. We needed to deploy 1 million community workers to support the contact tracing, and also establish a continental pooling mechanism using an online platform, which we have now established. This slide here shows you what we've done as Africa CDC to support member states. Over 200 rapid responders have been deployed to support 22 countries that have requested. We've also deployed over 10,000 community workers to support 21 countries that have requested that support. As we all know, testing is not effective if it's not a compound with contact tracing. So the whole PACT initiative was guided by the need to test, to trace, and to treat. The slide here shows you an interesting evolution. In January, no country in Africa had the diagnostics to support COVID testing. February, in February, we started with 2 countries in Senegal and in South Africa, and ramped that up quickly because because we had capacity in Senegal that we had developed and South Africa that had developed their own capacity, we were able to pull at least 16 countries to Senegal the week of February 8 and train them. And then the following week, we were in South Africa with another set of countries to train them. And we have since trained over 1,000 laboratory personnel to support different member states, distributed over 5 million COVID tests out of the 13 million that are indicated in Africa. I think there has been a remarkable progress in supporting this country. The platform that I indicated is here is called the African Medical Supply Platform.Africa. It is the equivalent of your Amazon.com or other electronic platforms where you provide a single online marketplace for all African countries to go in and procure their COVID response commodities. It is really a true indication of innovation and partnership with the private sector. And I must give credit to Strive Masiwa, who is one of the African Union Special Envoys that was appointed by President Ramaphosa to work with the Afri-Exim Bank, the United Nations Economic Commission for Africa and Africa CDC to set this up. I strongly urge that if you have time, you Google AMSP.Africa to see how the tremendous ability and capabilities of this platform. We've since, in terms of training, trained a whole series of people across different technical areas in surveillance, infection control, case management, as I said, laboratory risk communication, and up to about 2,700 publicly held emergency operations centers across the continent. This slide further shows you some of the things we've done, like training up to 4,000 people, individuals for surveillance, 8,000 in case management, 14,000 in lab workforce development. The slide here, I will not go through the numbers, but just shows other commodities for infection prevention, control, and case management. About 9,000 masks we've distributed as Africa CDC and a series of others that are indicated here. Let me move to leadership here. The first thing is really what I call the power of convening of Africa CDC. If you all recall, Ahmed was with me when we launched the Africa CDC just about 3.5 years ago here in Addis Ababa. And we were debating what Africa CDC, the unique role that it can play. And I think this COVID-19 has demonstrated that unique ability to convene. And it was really a remarkable exercise that within 1 week we were able to bring all ministers of health in Africa together in Addis Ababa under the leadership of Chairperson Moussa Faki. You can see on this picture Dr. Moeti, the regional director of WHO in Africa, and others to agree on the joint continental strategy, which we didn't have this mechanism when Ebola hit West Africa before. I think that is really the power of convening of the Africa CDC. And that led to the establishment of the joint continental strategy that I just indicated. Another thing that has been truly remarkable because of Africa CDC's existence is the leadership role we are playing in positioning the continent for a vaccine development and access. On June 24th, we convened a meeting of about 3,000 participants across the entire Africa, the world, to discuss Africa's needs to take center stage to develop in the development of vaccines and access. And you can see on the slide on the left, President Ramaphosa, who chaired the meeting, and Dr. Tedros, the regional director of WHO, and Chairperson Moussa Faki of the AU, who were all in attendance and to develop that strategy. So if you look back at why we are taking vaccines very seriously on the continent, I would like to invite you here to look at these headlines from the Wall Street Journal and the Washington Post in 2009. If I didn't show you the title that says Vaccine Nationalism in 2009, you probably think you are in 2020, okay? And it talks about the rich nations locked in flu vaccines as poor nations feared most of any vaccines for new flu strains could be claimed by rich nations, pre-existing contracts. That was in 2009. And today you see the same titling happening. So the unequal scrambling for coronavirus vaccines, why vaccines nationalism is winning, vaccine nationalism threatens global plans to distribute COVID shots. So I think as a continent, we are taking that very, very seriously, that Africa should not be left behind. And because of that, President Ramaphosa convened a meeting again on August 20th, co-chaired by the several 15 head of states, where I did present to them, as you can see on the picture on the right, the entire strategy for the continent, what we should be doing as a continent to ensure that we are not left behind. At the end of that, the head of state issued a statement, and I invite you to read the second sentence there. It says, they endorse the vaccines development and access strategy presented by the Director of Africa CDC and call for the acceleration of African involvement in vaccine development, Africa's access to vaccine supplies, and the removal of barriers to vaccine delivery in Africa. I think that is a very important statement that the head of state committed. There's a saying that those who do not learn from the history are doomed to repeat from it. So we're really taking this, the history, our past history, which is fairly recent, into account when we as a continent really are advocating for global solidarity and cooperation to make sure that we have timely access to COVID vaccines. If you recall what happened with the ARV, the antiretroviral treatment in 1996, it's really regrettable. This is a cartoon from what I captured called the Untold AIDS story, how access to antiretroviral drugs for HIV were obstructed in Africa. And you take the likes of the Nelson Mandela on the slide on the right-hand side to really begin to create a continental activism that led to access to ARV drugs on the continent. And this graph here shows you something that should never happen again. If you look at the blue lines carefully, the United States and Europe and more all developed countries had started having access to ARV drugs, that is 8 treatment drugs in 1997, because they became available in 96. But it will take 10 years, and you can see very clearly that the blue line declining is the number of deaths that started decreasing immediately. But in Africa, the red line, you can see that the number of deaths kept increasing. So for over 10 years, we did not have access to the drugs, and 12 million Africans died because of the lack of access to drugs. Thanks to PEPFAR, that was created in 2003, and the Global Fund, that Africa started having access to drugs, and then you saw the graph, the red line started decreasing there. I think this is a lesson we should learn and say this should never happen again in our own history as human beings living in the same planet, that we should have to sacrifice 12 million people for an intervention that was available on the continent. So we have now developed a vaccine strategy for the continent, a continent of 1.2 billion. Our estimate is that if we have to cover 60% of our population, we will need 1.5 billion doses of vaccines, and that is going to cost us about $10 to $15 billion to purchase and delivery. We are estimating the cost of vaccination to be, the cost of one dose to be $3.5. So this strategy has 3 pillars. They are indicated here to make sure we as a continent take part in vaccine clinical trials and development, that we have access to sufficient vaccine supplies, and that we remove barriers to vaccine deliveries and uptake. And we've since established what we call CONVAC, which is the Consortium for COVID-19 Vaccine Clinical Trials, which sets itself the goals to facilitate essentially vaccine trials on the continent, and also strengthening high-quality vaccine clinical trials and support and enable them so that they can actually be conducted in a most appropriate manner. And lastly, and more importantly, is to foster local manufacturing of vaccines on the continent. And this slide just shows you some of the sites that we've mapped out that can support clinical trials. The continent is used to doing clinical trials, so there is no shortage of that. And you can see here that if you have a vaccine today, you can put it in any of those slides, at any of those sites, because they are extremely capable of doing vaccine trials on the continent. We are also in discussions with the WHO and Gavi in what they call the Global Vaccine Access Facilities, COVAX. But we are also pursuing our own using the Afro-Exim Bank and other mechanisms to say, look, we trust and rely on the COVAX facility, but we need, as a continent, to look at our own bilateral negotiation, given what we are really, the continent is very concerned with the bilateral deals that are going on across the world. So the last one deals with regulatory issues, delivery and uptake. We are developing strategic plans on how these vaccines will be rolled out across the continent in a timely fashion once they become available. Let me just transition and end with an initiative we have just launched called the Africa Against COVID-19, Saving Lives, Economies and Livelihoods. As most of our economies begin to ease the lockdown, it's time to really look at the differences that are characterizing us and harmonize that. For example, if you look at the bottom part of that slide in green, we are seeing, notice that 29 countries are requiring that you have a negative PCR test to travel in the continent. 9 countries are requiring that you do mandatory testing on arrival, and 13 others are requiring that they quarantine you for about 14 days on arrival. So if we strive to unlock our economies in a coordinated manner, then we need to coordinate efforts. So we are using the whole of society approach to say we need to protect our borders and travel. We need to protect our economies and livelihoods and protect schools. So we've now launched that initiative. It will be rolled out from the 1st of October, driven by the Africa CDC. Let me just conclude with some key takeaway messages that as we ease the lockdown on economies, we need to coordinate our efforts using the whole of society to continue to scale up our testing, increase cross-border testing and enhance surveillance, engage the communities more because the communities must lead and own this process, but really build a strong public health measure so that we continue to wear masks, ensure physical distancing and proper hand washing. We have evidence that these measures are working. That is why 3 of the regions in our continent are showing a sustained decrease in the numbers. But lastly is really that we take COVID as a stimulus to build and rebuild a resilient public health system for our continent, knowing that once this pandemic is over, another pandemic will occur again. And lastly, to say that how can you help? I mean, as Med, you said, we have established a foundation called the African Public Health Foundation, where you can work with them directly. There will be, it's like the US CDC Foundation, the NIH Foundation, or the United Nations Foundation, where you can make your contributions available to them. Thank you for your attention.
Thank you, John. That was awesome. I'm going to now call on Dr. Will Ngwa, who is my organizing partner in crime, if you will, to take this over and take over the questions and comments for you. But I learned so much from you, John. I mean, you're brilliant, and your understanding of the dimensions of the pandemic on the continent are absolutely superb. So let me turn it over to Dr. Will Ngwa.
Thank you very much, Mel. I want to echo your comments about John's the talk. You know, as you already see, it's really impressive, John. We are very proud of you. It seems like you were made for a time like this. Actually, looking at your bio sketch, you know, thinking about how you got trained and then came to the United States, worked here in the CDC in the United States, and then actually returned to actually do this. And you were also trained in virology, which is like you're really made for a time like this. And we just really want to applaud your outstanding leadership in this. I know there are a lot of people who are brimming to ask questions. So at this point, we're actually going to open that up. But before we do that, I actually have one question. Can you elaborate a little bit more on the fact that, you know, what's the reason why Africa has had very little impact on people kind of predicted this was going to be much worse in Africa. I know you mentioned that the population is young. Is that a primary factor, or is it the measures that were taken, or is it because there's not enough testing? What is it?
So it's the first answer is really that the youthfulness of the population really is very important to note. And this is not just we've moved from being approaching this from an anecdotal standpoint to evidence. I think we now know that week after week we do countries through the coordinating mechanism, the task force, countries come in and share the data. And a vast majority of the infections are really asymptomatic. Okay, really, whether you look at Kenya data or Uganda or Chad, I mean, it's really, and if you look at the median age, is really young people, which is a reflection of what our population is on the continent. So that has helped. The other thing that we were very worried about, and you were worried about, we were worried about, is that the interaction between HIV, tuberculosis, and malaria, we just didn't know how that was going to pan out. And these are all infections that lead to hyper stimulation of the immune system. And you also know that from the 1918 pandemic, that the age group that was really affected so much at that time was the younger age group, because of the hyper stimulation of the immune system leading to a cytokine storm. So we're really concerned that a combination of these, but evidence, especially coming from South Africa, is showing that that is not the case, that the standard underlying diseases like obesity, hypertension, diabetes is contributing as much in those in that age in those people that have died. The other thing is that please do not underestimate the fact that countries in Africa went into lockdown very early on. We went into lockdown where we were reporting just 2 cases or 3 cases there. It had a severe impact on the economy, but it helped truly to blunt the spread of the virus there. And we have evidence for that. If you take South Africa, for example, if South Africa went into a lockdown where they had about 700 cases, they went into a lockdown. And before they did that, they were having a rate of increase of 50% every day of new cases. So if you look at the numbers today in South Africa, you say, well, they currently have 600,000 cases. But it could have been worse. They could have been having 1 million cases, okay, or 2 million cases on the continent. So that lockdown helped. And then when they had what I call the second wave, they did exactly that. They locked down, and they are now easing that, and you can see the curve coming down there. The testing issue has been, we need to shift gears from there and say that testing was an issue in March. We are not where we need to be, but we are not so desperate as we were in March. I think you can see the curve as I presented go up a lot. And if you look at the test ratio, the test per case ratio, WHO requires that we have a ratio of 10 tests per case. We are around 9 point something. Okay, that is so. So it's not we are not very desperate as we were as a continent so many months ago. I think that we still have a long way to go. We just need to acknowledge that. I think that's all. Then I'll just end up by saying that there's still a lot to learn for this new virus on the continent of Africa than what we have learned from. For example, who are the 1 million people that have recovered? So we really need to pool our data together and understand them more. And is it genetics? Is it the youthfulness only? And so who are the 3,000 people that have died? I mean, and why have they died of? I think we really need to count all deaths in Africa and make all deaths count in our understanding of this pandemic.
Thank you so much,
Bill,
John.
could I ask a question before you go open it up? John, when we spoke in July, and we are just really starting to get a grapple with this virus, there was the word that out of Madagascar there was a solution that was going to solve this problem. You drink the juice and no more COVID-19. My question to you: what happened there, and are there any other prospects coming out of Africa that we ought to be paying attention to?
Yeah, we engage with the government of Madagascar very officially because at one of the briefings that I did to the Bureau of the Head of State, the Bureau of the Head of States, for those who are not familiar with this, is that the continent each year elects a president who manages the affairs of the continent, and then he has a bureau. And this year is President Ramaphosa. So he does that with about 15 other head of states. So the president of Madagascar presented, and we did follow through, and we said through diplomatic channels to the foreign ministry, said, send us everything that you've ever done with this remedy, called the remedy, or this herbal treatment. So they submitted us a dossier. We reviewed that, engaged with them, and said, look, we really need to sit down and design a proper clinical trial on that. And at that time, the rates of infections in Madagascar were very relatively low, and I think it could have been confused to the fact that that was there. But subsequently, as you all know, the situation in Madagascar took up very dramatically, and at this point, I think the Minister of Health raised an alarm that we needed to come to their support. We have been supporting them there. So it's still work in progress to understand the active ingredients in that, and we will be more than happy to continue to work with them to understand that through a clinical trial. Now we've developed a partnership with the WHO, AFRO, the World Health Organization in Brazzaville, to coordinate our efforts so that we can understand that in a more clinically determined and designed manner.
Okay, great. Before we ask a question, actually, John, later on in the hour we may have Congresswoman Karen Bass joining us. And I think it's important to one of the questions that will come up, comes to the back of my mind is, what would you ask the United States to do to support Africa? I mean, you showed that really nice newspaper article where, advanced nations are fighting to get these vaccines and quite dealing with their own challenges. The question is, can they actually get to support Africa? But if you had the ear of the US government to support Africa, what would it be? What would you ask them to do?
That's a very good question. If I had the ears of the US government, the first word would be a thank you to the United States government for what they have done over the years in supporting the continent to fight endemic diseases like HIV. Remember, HIV is still a pandemic in Africa. It kills over 500,000 Africans a year, and there are 1 million new infections there. So that would be my starting point, to say the support the continent has received from the people of the United States to fight HIV, malaria, and TB has been remarkable, and is a historical moment that needs to be celebrated, because without that, I mean, the continent was going through, the HIV/AIDS was going to disseminate the continent. That is for fact. I mean, the life expectancies had completely plummeted in several countries in Africa before PEPFAR. I think that is there. But I link that up to COVID and say that it is through those dying moments, those dark moments on the continent, that you really know your friends. I think that is, the United States leadership and the United States people were a friend of Africa when Africa was in dire need to fight HIV/AIDS, in dire need to fight malaria. They came through, and I think we expect that kind of global leadership, vision, and support will continue to prevail. I think the world has always been in a good place when the United States have exercised that kind of leadership that they exercised in 2002. And lastly is that by protecting and supporting Africa to come to overcome this is directly protecting the United States. Let it be very clear to everybody, and this is not just a message to the United States, that COVID will not be eliminated in the world if it still prevails in Africa, or if it becomes endemic in Africa. There is no way. The vaccines is not going to be a silver bullet. Let that be very, very clear. We just don't know how these vaccines will work. We don't know if it will be seasonal. We don't know if they will be like measles vaccines for life. So the best way to squash this virus and beat this beast away is just to be sure that the United States, Europe, and other rich countries facilitate access to COVID vaccines on the continent so that we can all be vaccinated and create a global herd immunity that will flush this virus away. Without that, I think we'll be in for a long haul as a planet.
Thank you very much. So I'm going to open up for some questions. The audience definitely very excited. I can see the feedback to talk to you. So I'm going to give a chance to Rebecca. Rebecca, do you have a question for Director Kengasa? You can unmute and ask your question. Okay, I'm just going to read the question since we didn't get Rebecca. The question is there fear, distrust, concern on the part of the general population regarding COVID vaccines?
Okay, I'm unmuted.
In Africa. Okay, great.
Sorry, I was trying to unmute and was waiting for you to allow me to join in. Thank you for a very wonderful presentation. It's so comprehensive at the same time and complex at the same time, very simple. I wonder if there is concern in the general population regarding the vaccine, whichever vaccine we're going to try in Africa, because there is distrust, there is fear of Africans again and again being used as guinea pigs. And there is tremendous concern here among African Americans and resistance to participating in vaccine trial or any kind of medical trial. So there's tremendous underrepresentation of African Americans here in all kinds of clinical trials. So I was wondering if you have heard or experienced hesitation or distrust among Africans there regarding the vaccine. Thank you.
Thank you. I think let me start with what we should not do as a people, as a continent, is that we have to. There should be facts, not fear, with respect to the vaccine immunization with any potential vaccine. Facts are that the continent is not is protected. We have strong institutions that will protect the continent against any substandard vaccines. The Africa CDC will stand up, is vocal. Africa CDC is not just a unit in Addis Ababa. It's made up of the best minds across the continent, the best scientists among the continent, the JJ Muyembes in DRC, the Chikwe in Nigeria, Amadou South. So there's no way anyone is going to dribble their way out and to say that this is immunized. For example, we received here, is right on my desk here, a note, a diplomatic cable from Russia talking about the vaccines. How do you want to partner with us? And we say, good, we want to partner with you, but let's do clinical trials first. Okay, so I think so we respond that, look, we are open to anything, but we want to test it here in our community, see what the results are, then we can make, but don't just test it in Russia and then tell us that the results were great, and then we do that on the continent. So every African can be assured that they will be protected. They are being watched over by the Africa CDC, and we will stick our neck as much as possible. I think that is the facts, not fear piece there. What must we then do? As a continent, we have to participate in clinical trials. If we do not participate in clinical trials, then we cannot be part of the solution. We have to be part of the finding the solution. Second is that we have very capable Africans that have conducted clinical trials over the years. I mean, multiple clinical trials over the years, and they've been extremely well trained, and trials for Ebola, trials for malaria, trials for HIV. So we know how to do trials. So it's just not because it's COVID that we should be stigmatized. I think that should not happen. The last thing is that we should all work together collectively to counter social media in all our own rights and respective capacity, because the social media provides, of course, is the world we live in. We can't wish it away, but we should make sure that misinformation is countered as much as possible, and that we spread the right information. The currency of trust with the community is right information, and we should make sure that that currency is amplified as much as possible. We ourselves, as Africa CDC, have embarked on a large-scale perception study for vaccine. We're calling it it's the knowledge, attitude, beliefs, and perception of vaccines, so that before they ever become available on the continent, we know the mindset, we know which populations may potentially be resistant, so that a vaccine we make a difference between having a vaccine and having vaccination. We don't want to end up in a situation where you have vaccines and they are sitting in the cool house, and then there's no vaccination because you don't have access. People are not willing to take the vaccines.
Wonderful. Yeah, thank you so much. I'm sure I saw with the nodding of Rebecca that she looks very satisfied. All right, we have one more question from Jeanette. Jeanette, can you unmute?
This is a great.
Go ahead, Jeanette. You can see.
Yes.
Yeah, go ahead.
Yes, I'm in mood. I wanted to thank the presenter, Dr. John, and then also take this opportunity to say hi to Melvin for his persistence. I wanted actually to thank African leaders, because overall they have very well handled the situation. However, the economic situation and then also the social effect of the on the population, especially the vulnerables, the disabled groups, as resulting from the corona pandemic, were really, really disproportionate. So we would like to know if Dr. John can elaborate how the diaspora was engaged the same way we were engaged during the HIV/AIDS crisis. And then also regarding the social economic situation, according to the African Union, Africa has 84 million of persons with disabilities. So myself, I run a show since March to actually educate, promote the inclusion of persons with disabilities in the process. Unfortunately, it didn't really happen. So I wanted to know also if Dr. John can discuss with us the post-COVID-19 recovery process, how this can be inclusive. Thank you.
So a couple of thoughts. So Will, can I respond to that? Hello?
Yes?
Absolutely, yeah. Go ahead.
Okay. No, I wasn't sure that it was. So I think that let me say this: we are at war against this virus. I think as many things. When you're at war, you are really you're fighting. You're using all the arms that you have in your toolkit to as much as possible. I don't know that we have seen any data that speaks to the disability being impacted differently from the general population. I think, again, not knowing doesn't mean it doesn't exist. It just means because we are at war, we are really focusing on how do we get the diagnostics out there? How do we get the PPEs there? How do we make sure we are massing? I mean, that we may not be, we might be blindsided to analyzing the different components of the population to understand gender differences. There will be time for that. We need to do that analysis to understand all of that. So I think I take your comments. But my second reflection is that this pandemic has done already three things. I think we should also be sure that we don't put this in the past. Okay, because we are still have a long way to go. A long way to go. We truly don't know how the trajectory will look at. We are seeing encouraging trends, but this is a treacherous virus, and it can maneuver its way back into a scenario that will be embarrassing. But anyway, there are three things. This virus is teaching us that collectively we are more vulnerable than we thought. Okay, regardless of our wealth, our standing, whether you call yourself a developing country, medium income country, or a developed country. I think yes, I usually say that we all strive to flatten the curve, but the virus has flattened the world to show that, look, we are all extremely very, very vulnerable. Second, it has shown us that we are more connected than we thought. Whether you are you have disability, whether you are gendered, whether you live in the United States or China, that within 8 months, the world can be united and harmed. So I think that thirdly, it shows inequalities. I mean, serious inequalities that have existed, but it exposes it. So the inequalities also exist with a disability, and then with other things. I mean, the race, the gender, and others. So I think COVID is teaching us more and amplifying things that we thought we knew in a manner that is unprecedented. I think that is the last thing is about the post-COVID. Yes, we are beginning to think of post-COVID recovery, and we just wrote. I just wrote a perspective in the journal Cell, which we're calling for a new public health order for the continent. And that new public health order says there are 4 things we must do, and do them in a very mindful and deliberate fashion in Africa. One is that local manufacturing of diagnostics. The picture that I showed, that the delayed diagnostics should never happen again. It's not difficult for a continent of 1.3 billion people to say that we can devote resources and develop diagnostics. That way we don't need to be begging for diagnostics in future when the next outbreak or pandemic happens. The second is vaccines. The headline news that I indicated that should not be happening again. In 2009, we didn't learn. 2020, we don't learn from it. Then something is terribly wrong with us. We should really devote resources in research and development for existing diseases that will prime us and prepare us to develop vaccines when these kind of things happen, and we are not crying as like, don't leave us behind, as we are currently doing. The third thing is manufacturing. We import 99% of our drugs in the continent, and the continent of the future in 30 years will be 2.4 billion people. Cannot be depending on that kind of level of importation of drugs. Therefore, I mean, that is all part of the recovery. And lastly is the workforce. We have to develop our workforce. We currently need 6,000 epidemiologists. As a continent, we have 1,900 epidemiologists, a continent of 1.3 billion people. It has to change. And I think those are all ingredients of a new public health order that the continent should be investing in and thinking through, and committing our own governments to investing their resources into strengthening the areas that I just indicated as part of their own security apparatus and economic protection of the continent.
Will, can I jump back in? I have a question to you. It's kind of political, John, and I know you're at the Africa Union. But how is Africa's leadership responding to COVID-19? Have they learned? Are you seeing innovative leadership? What is your opinion about Africa's leadership in addressing the pandemic?
No, Mayor, I think it's a question that I'm very proud to be sitting where I'm sitting today, and this is not a political answer. I'm a technical, I lead a technical agency, and it's truly an honest, direct technical answer. I have not seen the kind of leadership that has been exercised across the African Union, as in fighting diseases, as in this particular case. The President Ramaphosa and Chairperson Musa Faki have been just simply outstanding. They do convene every 4 to 6 weeks. I think the last time I indicated, I showed you on the slide, was the 22nd of August. I think I'll be, I'm expecting that next week or the week after, they'll be coming back to review the action items that were taken at the last bureau meeting. I think that is, and I've done that briefing for the last, about 6 briefings to them, and we chat strategy, they support us, and they just last Friday, the President Kagame and President Ramaphosa were at a meeting on a call in the accelerator meeting in Geneva. Immediately after that, President Kagame called and his office called and said he wants to understand what I'm doing to engage in this and what kind of support that is required. Engage in this, meaning the vaccine discussion in Geneva. So I've not seen that in my 32 years in public health and 29 years of those in HIV, seen the leadership, the entire leadership of the continent mobilize and really and not just participate or attend meetings, but seriously interrogate data on data. They have since now request that I submit them to them, the Bureau of the Head of State, on weekly basis, the data analysis of the continental epidemiologic situation. Second, they have established a COVID fund. Okay, the African Response COVID Fund, that we just had a bureau meeting of that, the governing board of that yesterday, and next week there will be a big mobilization across the continent chaired by President Ramaphosa and the board that runs that fund to raise more resources from the continent to support the COVID response, and that fund is strictly to support Africa CDC's the response initiative. So I think on a scorecard, I will give them an A+.
Wow, that's wonderful. And I think it makes it easier when we have somebody like you who's really helping to coordinate this response from the leadership. One thing that I have, when you talked about the diagnostics, one thing that, so I'm actually been invited to write this article for Science about Africa, COVID-19 and cancer in Africa and addressing the dual burden of the disease. And so one of the things that happened at the beginning is that, a lot of reprioritization away from non-communicable diseases like cancer. And so, some centers usually send their samples, their pathology samples outside of Africa for diagnostics. And because of the lockdown, some centers are reporting that they could not no longer send those samples for cancer outside. And so, so patients and then prevention and all of those things was shut down. And so a lot of cancer patients really felt the brunt of this. So the question is really, is there, can you comment on how Africa is addressing the dual burden of these communicable diseases and also non-communicable diseases like cancer? Is this something that you're actively thinking about doing, or is it something that you've really addressed?
I mean, we have to think of it in the spirit of the new order that we are proposing, that we integrate this local manufacturing into and developments into our public health preparedness, and not just, see this as part of the private sector investment there. So there are three pockets of challenges that we face. And so if you put COVID outside and you say, well, how has COVID impacted our three pockets of the syndemics? One is the non-communicable diseases that are really on the rise. I think that is really what is going to haunt us in the next, in the coming decades, is the cancers, the diabetes, the cardiovasculars, and what the shifting patterns of these diseases. So that is one pocket. Then you look at emerging and re-emerging infectious diseases. The Ebola, as we speak, I'm surprised that you have not asked a question about Ebola. There's Ebola going on in Western Congo. I mean, as we speak, 120 cases, about 60 deaths. And so it's there in the Congo. So Congo, as a country, is fighting a vast outbreak of measles, a vast outbreak of vaccine-derived polio, a vast outbreak, pandemic of COVID-19, and Ebola. It doesn't seem like we are going to leave anytime soon. If you recall, 2 years ago, we were in Bandaka fighting Ebola. Then we removed our responders to DRC, and we're all celebrating. Then the next week, they said we have an outbreak in North Kivu. We routed them from Kinshasa to North Kivu, and when that was declared over, it was declared in Western. We routed them back to Western, back to them. So that COVID is impacting that. The people that we have now in that theater theater of response include people that we're trying to make sure that the COVID and Ebola do not overlap, because if they overlap, it becomes a very volatile situation there. So then the third piece there is really the endemic diseases, the HIVs, the TBs, and the malaria. So we have to take that as a collective and see what COVID is doing and impacting all three pockets that I just described. We have just announced a conference next year, and that is the first. I mean, when I look at the continent and the issues we are discussing here, I said to myself, we need to bring everybody together, and we have a dialogue. And that conference will be on May 14 to the 16th of May 2001. It's going to be, paradoxically, the first conference on public health in Africa that we will be hosting at the African Union. And that will include both non-communicable diseases, the cancers, the HIVs, the endemic diseases, and of course, COVID. The theme of that, it will be COVID 1 year later in Africa. What have we learned from COVID? And how has that impacted private sector? The economies, the HIVs, the cancers, and immunization programs there, because it's just going to have a significant impact on our health systems as a whole, including not just cancers, but the other things that I just described. So please mark your calendars, and you're welcome to attend that conference in next year.
Great. We are going to mark our calendars. I just noticed that Congresswoman Karen Bass has been able to join. So, Meryl, would you like to introduce? I'll hand over to Meryl to introduce her.
Great. Thank you very much. John, stick around. Make sure you hear with the Congress. I'm very honored to welcome Congresswoman Karen Bass to the forum. Congresswoman Bass is the chair of the Congressional Black Caucus. She's also the chair of the House of Representatives Subcommittee on Africa. She was also, as many of you have heard, she was vetted to be the vice president for the Democratic candidate, Joe Biden. Some of us think she should have got that nod. She's our favorite person. She's also a neighbor of mine here in Washington, and she's a very good friend. So without further ado, let's hear from Congresswoman Karen Bass. Welcome, Congresswoman.
Oh, thank you, Mel. I really appreciate you for inviting me to offer remarks today. I also want to congratulate everyone involved for putting together another wonderful series, and of course, for your continued commitment to working on Africa issues. Everybody knows me. One of the big reasons I wanted to come to Congress was that I could work on issues related to the continent. And as usual, I know that this program addresses many of the most pressing issues facing the continent, and this year's focus on COVID, of course, is no exception. So we're here to discuss the impact of the pandemic on Africa. And I saw from the program, I know that one of the segments is entitled, "Is Being Black Bad for Your Health?" Well, I don't know about Africa, but it sure is bad for your health in the United States. So this is a serious and important question. And as of yesterday, you know that the number of confirmed cases worldwide continued to head toward 30 million. And in the US, the case tally has climbed over 6.6 million people. And I believe by the beginning of next week, there will be more than 200,000 deaths in the United States. And I know everybody here is aware that this disproportionately impacts people of color, whether you're talking about Black folks, Latinos, Asians, Native Americans. And the thing about the United States is this is just inexcusable. It is not because we don't have the resources, the technology, the scientific wherewithal. It is purely because of a lack of leadership. So we know that there are these vaccine trials, but we also know that they're failing to recruit folks of color, and for good reason, because we do not have the best history in this country of, number one, doing clinical trials that are diverse. Clinical trials usually apply to white men. They don't even cover women, and they certainly don't cover people of color. And so the tri-caucus, we call the Black caucus, Latino caucus, Asian caucus, and the two Native American women, we are working to make sure that the clinical trials are diverse. Now, we know that when there is a vaccine, that the essential workers are the ones that need it first, but we know that a lot of the essential workers are folks of color. And so we have to make sure that whatever happens is safe. Now, I'm very concerned that in our country, it has all been entangled into politics. And so frankly, I think realistically, scientifically, it's going to take until the middle of next year before there is a vaccine. And then it's going to take quite a while for that vaccine to actually ramp up to cover folks. And hopefully in the next 46 days, we will be able to right this ship in the United States, because I am worried that if things continue to be covered politically, that we are going to continue to have a lot of deaths. So as of September 16th, and I believe the earlier panel covered this, I know the death toll in terms of Africa is approximately 33,000 people. And that includes the former president of the Republic of Congo and Somalia's former prime minister. But some people think that the death rate on the continent is probably a lot higher, but might not be documented either in terms of infections or deaths. But I also think that the African countries, many of the African countries, quickly ramped up disease surveillance, case isolation, contact tracing, behavioral change campaigns, and in early 2020, drawing on lessons from other pandemics. So I think it's really important that we give the African continent the credit they deserve, and that they were a lot more, they were a lot more focused on science than we were here in the United States. So I know that many of the African countries imposed early restrictions on international flights. I will tell you personally, I was so disappointed as having the opportunity to chair the Africa subcommittee. I had certainly planned on wonderful Codels this year. That didn't happen. And I'm frankly worried that they might not happen next year either, because there's just no end in sight. Because not only has there not been strong leadership in the United States, if we had had better leadership here, I think internationally things might have been dealt with better. And I remember Ebola, and I remember the way the Obama administration jumped on galvanizing the entire world. So I think it's just important that we're able to get back to that, and that's why I cast a lot of hope on the next 46 days. So we know the economy of countries across Africa have been heavily impacted by the pandemic. And we know that there have been global pandemic-driven national lockdowns, border closures, and restrictions has disrupted the African economy. And if I think about it, that's the other thing that's so sad, considering that the progress that had been made in so many African countries, and the idea that the World Bank is even forecasting that the pandemic could push up to 39 million Africans into extreme poverty. And so here we've made progress to fight extreme poverty, and then we have a pandemic that pushes people and pushes economies and pushes countries backward. The World Food Program anticipates that COVID-19 will aggravate existing challenges and may leave 143 million Africans facing acute food insecurity in 2020. On the healthcare front, I'm also concerned about losing many of the gains we have made in HIV, malaria, TB, and vaccinations, and any disruption in treatment can mean lives lost. So I'm concerned that once a vaccine is available, we better make sure there's equitable distribution, and we better make sure that it is safe before we rush out and implement it. So another major concern I have is education. Huge issue in the United States. We already have this massive achievement gap between white and students of color. And now I think about how that gap is going to be a gulf by the time we are past this pandemic, because we could have in the nation kids out of school for a year or more. And so I think about kids in Africa and the concern that in education in many African countries, it's not free. And so if parents aren't working, how are they going to be able to pay school fees? So the bottom line is that the pandemic is exacerbating previously existing educational inequality. So what I'm trying to highlight is that the pandemic has exacerbated long-term systemic inequalities domestically here in the United States, but also globally. And as we build our response, we need to continually focus on addressing the root causes of many of the challenges that face both communities of color in the US and African countries. So one of the things that I believe we need to think about as we move forward and try to address the crisis at hand, we need to be thinking about the future, because once we are past this, we need to use the crisis as an opportunity to say, the continent of Africa needs a Marshall Plan. Frankly, communities of color in the United States need a Marshall Plan. And maybe we can not just go back to business as usual, but maybe we can use this crisis, devastating as it is, to say, let's take a leap forward and let's have the world understand like we have never understood before. We are all connected. I don't care how far away we are geographically, we're only 10, 12 hours away on a plane. And I think this pandemic has demonstrated it, because the entire globe is going through it at the same time. So I want to thank you. As always, Mel, your leadership is always strong. You're always at the forefront of the issues. And I appreciate the opportunity to speak with you today.
Thank you very much. Dr. Nkingasong, I want to give you a chance to make a comment before we lose the Congresswoman.
Thank you, Mayor, and thank you, Congressman, for it's a pleasure always to listen to you articulate African issues. I think we, as a continent, are extremely appreciative of the support, the global health leadership that the people of the United States have always played in supporting the continent to fight its health challenges, which is really the underpinning of our development. The HIV, the PEPFAR program stands there clearly. I think you have joined the program before I think the program before I indicated that. I think we also recognize that none of us will be safe in the world if COVID continues to prevail anywhere in the world. So I think as a continent, we continue to look forward to the strong leadership from the United States in fighting this pandemic, not just in the United States, but in Africa as well. So we look forward to staying in a collaborative, in an expression of a solidarity across the Atlantic, so that that bond, the strong bond between the people of Africa and the people of the United States continues to prevail. Thank you.
Thank you very much. Congresswoman, I'm assuming you have to leave. So thank you very much for your time and effort. Always great to hear from you. And I turn the program back over to Will.
Thank you so much, Mayor. And thank you to the Congresswoman and John for this past couple of discussion that we just had. Sorry, I think at this point I'm going to turn over to our colleague, James Calvin from Johns Hopkins University. He's going to moderate the next part of the session. And before that, actually he's going to introduce our main speaker for this hour. Is going to be Dr. Garvey. And maybe Dr. Garvey will start by giving some feedback on the talk that John gave earlier on as well, and maybe comment on the Congresswoman. But then after that, Dr. James Calvin will take over. Dr. Garvey, are you there?
Thank you, Will. Can everyone hear me? Wonderful.
Garvey?
Yes, I'm here, but I don't know what your sequence is, Will. Is it James or me?
I was just going to say, Dr. Julius Garvey, son of the legendary Pan-Africanist Marcus Garvey, is an accomplished surgeon, well known for his activism in health and social justice. And so we welcome you again with us, Dr. Julius Garvey.
Thank you so much. And it's good to be present with so many brilliant people dealing with the current health crisis and health problems across the globe. I think I'm going to, Will asked me to make some comments on the previous speakers. And I don't dare pronounce the last name of our first keynoter, so I will call him Dr. John. Is that okay? It's not out of disrespect, but being in the diaspora, I'm not sure I'd get your last name correct. I think, clearly the CDC, if not Africa itself, needs to be congratulated in terms of its fantastic response to COVID. And the point of leadership has been brought up, and I think definitely one can compare and contrast the leadership that we've had in Africa, where, of course, many times over the past umpteen years, African leadership has been criticized, but we've seen African leadership really being in the forefront. And the CDC is doing a fantastic job, and I certainly like the concept in terms of going forward with the Africa Public Health Foundation. And I think that analysis needs to take place as we go forward. Certainly, COVID is not over, but we need to analyze the situation. And I'm very appreciative of the understanding that, Africa has to do its own manufacturing, whether it's masks, et cetera, vaccines, and all the way down to drugs. And the lessons learned in terms of HIV and medications for HIV, which we didn't have. When I say we now, I'm considering myself an African. We didn't have on the continent or here really in the diaspora because we weren't manufacturing it. And we should have learned the lesson then that we have to manufacture our own medicines. And we see, again, this is a failure partially of a certain amount of leadership, meaning that, leaders will go abroad to get their medicines or to get treated, so that our healthcare systems in Africa have not been developed appropriately. I think another lesson learned, which came out in the talk, was the mobilization of community health workers, lab technicians, people who are tracing the disease and testing and so on and so forth. So there's a great focus on the top down, meaning MDs and PhDs, et cetera, but healthcare to a very large extent, especially in terms of prevention and information, and even the early stages of treatment are carried out in communities by community health workers. And this has been one of my beefs for a long time, that we don't focus enough on the bottom aspects, so to speak, of our healthcare system. It has to be the pyramid, and the bottom has to be wide, and the top can be narrow. John mentioned, epidemiologists. I think that's great. But for every one epidemiologist, maybe we need 10,000 community health workers. So that I think, that should be one of the lessons learned, as well as the manufacturing, et cetera. Not much to say about what Congresswoman Bass said in terms of the inequalities. Here in the United States, it's endemic. John talked about endemic diseases in Africa. Well, one of the endemic diseases in the United States of America is racism and white supremacy. It's been endemic for more than 400 years, and it's not only endemic, but it's systemic. And if we transition a little bit to our current situation in terms of COVID here, we see that African Americans are dying at a rate of at least 2.5 times the white population. And it's due to any number of factors that are built into the system, not least of which is the economic inequalities. And then the other disabilities in terms of lack of access to healthcare and health insurance, the environmental challenges, we're redlining and so on. So we're near the railroads, or we're near the dumps, and the lead paint in our houses, the lead in the water. So there are enormous numbers of the toxic environment in which we live. It's widespread. It's all around us. As a people. And, not least of the toxic part of the environment itself is the way in which we are perceived, and the way in which this is carried out with the society. And of course, we see how the militarized police carry out these perceptions, so that it's dangerous to breathe while you're Black. And certainly George Floyd, Eric Garner, people like that have demonstrated that. I mean, it's criminal in a society where you can't breathe, because that's fundamental to life. So that the life of Africans living in America is being squeezed out of us by the militarized police. You know, you can't walk down the street, Trayvon Martin, and somebody shoots you because of what they think in their mind, which is their disease. So we have basically psychosis, neurosis, and definitely disordered mindset in the majority community. And we are suffering from this. And this creates the stresses. And studies have been done, for example, on the telomere, which indicates the biological age of people. And it is shown that the average Black woman biologically is 10 years older than the average white woman of the same chronological age. And this is due to the stress in the environment. I don't know that the studies have been done for men, but I'm sure that is similar. So we're aging faster. In terms of environment, we know that what has happened in terms of Black communities, you know, the fast food joints, et cetera, they're maximized in our communities. Whole Foods is not in our communities. You know, it's upscale. So our choices in terms of food, by the way, way back in the 60s, the average, you know, Black household had a healthier diet than the average white household. And that was because Blacks used to grow our own food, et cetera, in the backyard at different places and so on. But of course we got integrated, and this is what happened, you know, in terms of being integrated into the economic system. You know, the fast food joints came into our neighborhoods. We see the advertising whenever a program is focused to the Black community. It's all KFC and you know, the other fast food joints. So that our environment, both in terms of, I mentioned lead, in terms of the air that we breathe, in terms of the food that we eat, that creates disease. And the common factor of all that is the stress that we mentioned. So that the disease starts from the stress in our minds, you know, the hormones that are released in terms of cortisol, in terms of adrenaline or adrenaline. These are stressful situations that that should only be in our bloodstream under extreme circumstances when we're being attacked or whatever. But our environments also, you know, are fairly hazardous. One doesn't know, you go outside the street and you may get shot. You know, as we, I think we mentioned, you know, Amadou Diallo, he was standing on his porch and he was shot 20 times. I think 40 bullets came his way. So this is the kind of environment that you live in. This is the stress that you have. These are the hormones that are going through your system on a daily basis, not just in an emergency once a month or once a year or something of that nature, and it destroys your health. So the food situation that we talked about leads to obesity and poor food choices. You know, the high fructose corn syrup, the hydrogenated fats, and so on. So we have a population, so the general population is 60% obese. It's higher within the Black community, and morbid obesity is about 40%. And this gives rise to the non-communicable diseases that you know, well, was briefly mentioned early on, such as the diabetes, the hypertension, the stroke, and the other cardiovascular diseases, as well as cancer, as well as asthma. And you can go on and on. Because one of the things that is only now coming to light is the whole business of epigenetic influences on the DNA. So that we have this environment, we have this stress, and it turns on certain genes and it turns off certain genes. So we, I don't know, you know, I don't know how to put it. It's not just being Black is hazardous to your health. I think that's the title of my talk. And certainly being Black in America is hazardous to your health in terms of a chronic situation and in terms of acute situation. Because as with Breonna Taylor, you could be inside your house and they batter down your door and shoot you. You know, so it's cradle to grave. I mean, meaning for example, that for the Black mother, there are more low birth weight children. There are more premature births, and there's higher maternal mortality, there's higher infant mortality. Our lifespan is 3 or more years less than the average lifespan of the white American. And the diseases that I've just mentioned, all the way from obesity through cancer, is much more prevalent within the Black community, and our access to healthcare is less in terms of insurance and in terms of clinics, et cetera, and we have less access to information that would allow us to choose properly in terms of, you know, our lifestyle. So the bottom line is systemic racism that is part of the culture. It's been part of the culture for 400 years, and it takes an enormous toll on the African American, you know, population in terms of their physical health. And we have not gotten into mental health, which that's where it starts, because we have very often a dependency syndrome, because some people call it the post-traumatic slavery syndrome. Whatever title that you give to it, we live in an environment which every day more or less dehumanizes you in terms of who you are. To maintain your identity as a human being who is satisfied with him or herself, it's a constant fight. You know, it's who are you? Myself as a doctor, you know, going on the wards of the hospital, the nurse would want to know who I am when I'm reading the chart of my patient. They assume that I'm there to clean the floor. And, you know, this is at all levels. Can you imagine the poor laborer, et cetera, et cetera. So systemic racism is hazardous to the health of the Black person. It takes a tremendous toll, and you know, we need to de-link from it. And my father said, you know, more than 100 years ago, we have to liberate our minds from mental slavery. And of course, you know, that's a whole thing, but it does start with the mindset. We've been disconnected from who we are in terms of our history, in terms of our culture, in terms of knowing ourselves. As you know, way back in our earlier civilization, Kemet, the mantra was know thyself. And we need to know ourselves as African people with a history and a culture to be able to stand up to the vicissitudes of systemic white racism. So, you know, I think I've painted a little bit of a picture, and I think it's up to the panel to tease out whatever else they want to tease out of being Black in America is hazardous to your health. Thank you.
Thank you, Dr. Julius Garvey. I think you have prepared the panel and all of us who are here today to further our conversation. I'm James Calvin, as mentioned before, a partner with CFA and Harvard and in the Health Forum. So let me move along and say also that Dr. Garvey, along with the previous keynote address, really have provided for all of us today a view of the world where the diaspora, the African diaspora is. So these are critical and key times. So let me move along quickly. And we'll come back to you, Dr. Garvey, because it's important to hear the voices of the other panelists. I'm honored to recognize and introduce each of them this morning. They're powerful, and we ask that each of the panelists, given the framework that has been set in our dialogue today, begin to talk from their perspective what they see and how they respond to is being Black bad for your health. So let me just briefly introduce them, and then we'll ask each of them in the order in which they're introduced to begin to respond so that we can move the conversation forward. Dr. Kenneth Njiwa is an associate professor of Hebrew Bible at Drew University Theological School, and he's director of the Religion and Global Health Forum and serves on the leadership team for Never Stop Breathing. He will be followed by Calvin Johnson, a future Hall of Famer Calvin Johnson played as a wide receiver for 9 record-breaking seasons. And I'm going to say with my hometown, Detroit Lions, because I'm out of Detroit. In 2008, he founded the Calvin Johnson Jr. Foundation, which has educated, trained, and provided services in social development to thousands of at-risk youth and their families in Michigan and Georgia. Rob Sims. Rob was an offensive lineman for the Seattle Seahawks and the Detroit Lions during a successful 9-year career with the NFL. He currently serves as a founding partner for Locker Room Consulting, and that is in relationship with Calvin Johnson, which I neglected to mention before. We have Sharon Williams, Drew University and Harvard Medical School, and has served in the Social Justice Leadership Project at Drew Theological School, and has been recognized for her sensitivity to the mental, emotional, spiritual, and physical well-being of others. Eric Broyles. Eric is the founder, chairman, and CEO of NanoCan Therapeutics Corporation, a Princeton, New Jersey-based biotechnology company. NanoCan deploys cutting-edge nanotechnology innovations to develop and commercialize therapeutic medicines to treat certain cancers and respiratory diseases. He is also founder and chairman of the board of Expert Connect. Okay, by those brief introductions, I would like to call on Dr. Kenneth Nijawa to get into our conversation.
Thank you.
Kenneth, are you?
Yes.
There you are. Very good.
Can you hear me? Yes.
Yes, we can, and see you.
All right. Wonderful. Thank you so much for the invitation to be part of this conversation. I am really inspired by what we have heard so far from Dr. Kengeson and Congresswoman Karen Bass, and from Dr. Garvey. Dr. Garvey said, know thyself from the ancient Egyptian Kemet. And as Black people, I think we can lean on that long history of sort of Africana philosophy and religion to better organize ourselves, to know how to address what we're facing. So I just want to mention very briefly, since we have wonderful speakers coming up, I just want to mention briefly that, yes, I am a part of the Global Health Catalyst that started at Harvard. So at Drew, we have a Religion and Global Health Forum that grew out of that. And over this summer, with the killing of George Floyd, the question about how Black people breathe became sort of central for us. And so we started to think about the ways in which, as Black people, we can develop ideas, programs, and platforms that help us address the intersections of racial and health inequities that are a part of our common existence. If there are systemic problems, then we need systemic solutions. And so one of the things that we settled on was the approach that says, how do we take a trauma and translate that into a creative moment of resistance, but also of creativity that allows us to breathe, because we have a mandate to breathe. And as a religious person, I think of that mandate as a religious mandate, a mandate that we have, which is a fundamental right that nobody should be able to take that away from us. And there are multiple intersections on how we can do that. So for us, what we settled on was 8 minutes and 46 seconds is the time, the traumatic time that we know associated with George Floyd. In a homeostatic move, which is partly how Africana people have dealt with historic traumas, we wanted to say, can we take that 8 minutes and 46 seconds and turn it into a movement where we say, never stop breathing. So that's where we got the idea of never stop breathing as a movement to resist the the statistical trauma, the historic trauma, because learning from the late African philosopher John Beatty, he said African descended people, they think not just in terms of statistical time, but in phenomenon time. And if we think in terms of phenomenon time, then we can take that trauma, 8 minutes, 46 seconds, and transform it into phenomenon time and create ideas, platforms, and programs that will allow for us to identify the systemic racism that makes being Black hazardous to our health and say no more. We will never stop breathing. And we will insist on putting in place processes that help us to keep breathing as a community. Thank you for this invitation, and I look forward to listening to my other panelists.
Thank you, Kenneth, and we may get your voice again. Very much appreciated. Calvin Johnson, please, if you could join the...
Yes, can you hear me?
Yes, we can, and we'd like to see you, and we think once you turn that camera on.
Let's see here. I'm on here twice because my phone and my and my computer. Yeah, I'm on here visually on my computer though.
Okay, there you are. Good to see you.
Sorry about that. All right. You know, I would go back to a story when I moved to Michigan. Well, actually, more specifically, when I moved to Birmingham, Michigan, back in 2012. And you know, when I moved to Michigan, Birmingham, I noticed there's one thing that I didn't see anywhere else in Michigan amongst all the Black communities. And as we're speaking about, you know, being Black and being hazardous to your health, not one fast food joint is around the area where I live. And obviously it's predominantly white. The county in which I live is 14% white. The city in which I live is probably less than 10%. So, you know, in the 5 mile radius, there's nothing there. But once you step below, what is it, like 11 mile, where the Black population begins, you see the Checkers, you see the KFC, you see all of those. So yes, it is. I see there are ways that, you know, you come up with the way that, yes, being Black is hazardous to your health just because of where you can reside. Solutions that Kenneth had talked about, I like to piggyback off of that. Those are awesome, you know. But you know, it takes, you know, someone like, you know, the people like ourselves that are on the ground level, you know, have the foundations, able to educate our youth that are coming up. You know, some of us like myself, and you know, we know what we know. We're knuckleheads, but we're able to learn, you know, and pass on this information. I think to the younger generation that's coming up and educate, will be able to pass that message along that Dr. Kenneth Kenneth so eloquently put together before me. So being able to be here and push that message, push that agenda, push what the education aspect of it is why. Why I'm in the position I am in, and what I feel like my mission is. Why am I able to be at this table with you guys today? So it's awesome to be here. Thank you, and I'll pass it back to you, James.
Thank you, Calvin. We share one name together, and appreciate your participation, and we'll hear your voice later. So yes, thank you for that introduction. Okay, Rob Sims, please, if you could join in the conversation.
Yeah, you know, absolutely. I'm just going through the roster here and seeing everybody that's on here. Great to see you again, Dr. Garvey, Dr. Ross, always a pleasure. Dr. Calvin, I believe we met as well. It's just, never in a million years will I think I'll be talking to all these doctors and professional folks. I think when me and Calvin talked about locker room, and just a little background on me, both my father and my father-in-law played in the NFL. So I've got an understanding of what life after football looks like. But all that I kept thinking about was, you know, here we are, we have this population of young Black males that are becoming millionaires overnight, that are, when they're done playing, they go back and revert to where they are. And shame on some of them for not making good business decisions and not taking care of their finances. But mostly what I saw was that, you know, potential pillars of our community were being lost, and we were losing funding, and we were losing dollars, and we were losing support. And, you know, made it a mission of mine is to try to bring as many of those people with us. I'm very fortunate to have partnered with Calvin. We've got some other players that we're bringing into our fold with some of our projects. And, you know, for me, we need those leaders in our community. If anything that I look and see that we're missing, you know, we're missing some of that leadership. So we, you know, instead of telling the same old story over and over again, we need to help, you know, build those folks. And, you know, I believe that is a start in the right direction of getting people and getting our community the help it needs. You know, we all know the stories and everything that's going on, and it feels like, you know, every few weeks we hear another story that we just can't believe. And you know, it's not going away, unfortunately. But you know, just as, you know, people like Marcus Garvey and, you know, other folks that have you know, forged a path for us now to be able to even have these conversations about business and you know, having the freedom to do different things. You know, we must continue to fight on, and we must continue to focus on. In football, we always talk about, in the office, we always talk about everybody do their job. So you know, just as, you know, we sit here and talk about medicine and health, I think it's important that we still continue to develop our leadership. I think it's very important that we continue to educate and create awareness. And, you know, just as things did get better in the civil rights movement in the 60s, you know, right now we do have the voice of people, and it's our time to make as much progress as we can. And so things like this, I'm very appreciative to be a part of. And, you know, I look forward to the future, even though at some points it seems very dark. You know, being in business and being an entrepreneur, I understand that, you know, your bad days, your good days will outweigh your bad days, but you just got to keep fighting. So me and Calvin always speak about, you know, how we want to, you know, as we played, is how we want to run our business. And we want to just keep stacking good days on top of each other. And, you know, that's kind of our mantra and what we say to each other. And we want to just continue to push our ball forward, which ultimately will push our community forward. Thank you.
You're welcome, and thank you, and reinforcing each other and the persistence and with the community focus. So we'll hear your voice later. Thank you very much.
Absolutely.
Sharon Williams, please, if you can join in our dialogue.
Thank you so much, Dr. Will McGraw, for this invitation to share in this discussion within this sacred space. I am both humbled and grateful. I thank God for Dr. Garvey, Melvin Foote, Congresswoman Bass, James Calvin, the panelists. I bring you greetings from Drew Theological School, where I study with Dr. Kenneth Ngwa under the Religion and Global Health Forum. The question that has to be presented this season is whether Black lives matter. How do we reconcile this question of Black humanity in the context of the coronavirus, racial and health disparities across the African diaspora, are an open question for us all. As he worried about his own safety from the police, while simultaneously grieving for the loss of his loved ones to the coronavirus, a young poet, a brother named Dante Collins, responded to the impact of the dual pandemics of COVID-19 and the broader health threat of anti-Black racism with his poem entitled, "They Need Some of Us to Die." And he goes, "Hell nah, over my head, I paid mine. I checked Black and subtraction, and it knows what I did. Made Black a box to check. Subtraction doesn't need to even know a sigh of the season, the second breath my mother was taking, always trying to catch African, American, emergency. Subtraction doesn't know Black has many bodies, bodies of water through subtraction. sunken, gifting the sea new strange stones, subtraction, opened the barber shops and the bowling alleys, insisted the churches set us up, sent us home with inhalers. In God, we the people, degradation, a new package deliverance, homicide, hallelujah, I'll be damned, but I'll be back before I'll be burned. I'll be black and ain't slept since. Subtraction needs my blood to water their weapons, to subtract my blood. Do you see the necessity for dreaming, or else the need to stay awake, to watch, worried, the hand, invisible, make peace a sign? Thank you.
Thank you, Sharon. As we pause and reflect, a very ethereal poem for our time in the minds of who we are and what we can become. So we'll have your voice as we go forward. Very much appreciated in our discussion today. You're welcome. Eric Broyles.
Yes, sir.
There.
Can you hear me?
We can hear you and see you. How are you today?
Okay, I'm great. Thank you, sir. So the question is, being Black hazardous to your health? It certainly can be, as we have heard. But I'd actually like to look at being Black as a way of demonstrating empowerment. And for me, that comes in the form of looking at my life and the lives of many of you around this table. The society in which we live has set a standard for us. And the standard is quite a low one in many ways in terms of how we're treated, what we're supposed to do economically, academically, socially. So that standard has been set for us. So being Black is empowering to me because I live above that standard. And I set concrete metrics and targets to have real outcomes to exceed and crush that standard daily in my life. And I've done that academically by becoming the first African-American valedictorian of a 200-year-old university with over 4,800 students in my class, by attending a top 10 law school and graduating near the top of my class there, by challenging myself on what investments I make in our community. Before Robert Smith made his landmark investment in Morehouse, my 7-figure donation to the University of Cincinnati preceded his. Didn't get as much publicity because people don't know about me, but that's fine because I focus on executing every day and living above that standard. And I recognize as I encounter racism, there's a certain actually level of sympathy and empathy I have for racists in this country because many of them are trapped in a standard that they actually live beneath. And that is the standard of whiteness in our country is that you are to be superior. You are to be great. You've been imbued with the vision of Superman, Batman, Rambo, J.R. Ewing, and everything else that is great and that is superior. And that is your standard. And so you see many people who come from places like where I grew up in Southwest Ohio, poor communities where many of our white brothers and sisters can't live up to the standard that they should easily excel because everything in society tells them that they are supposed to be at that standard. And I think that's how you get a Donald Trump in the White House, is because that many of our white brothers and sisters look against a mirror and reflect against a standard that they can't achieve because it's largely built on a lie of this notion of white racial superiority, primarily in intellect, because guys like Calvin Johnson and Mr. Sims helped to break the theory of physical superiority as Jesse Owens first did in the '36 Olympics. but the intellectual belief of intellectual superiority is what permeates. And Barack Obama helped to shatter that by having a positive image of a black male on TV every day that undermined the very reality of what everybody had been taught. And Santa Claus was kind of taken away from America. The thing that gave a gift every year that felt good, that your parents told you about, that you believed in, and then you found out it wasn't true. And so being Black to me is an ability to be empowered and to live above the standard in the narrative and the statistics that this society sets for people who look like me and who look like us. And I revel in shattering that standard every day.
Thank you for those powerful thoughts and comments, Eric Broyles. A couple of thoughts come to mind immediately, and as we go forward, hopefully we'll get more of your thinking. The importance of standards, the importance of giving and committing, why there's the giving. It's both Barack Obama and Michelle Obama. It's the family. And if we think of those two wonderful daughters of theirs, right? Because, you know, it's a collective, right? And then the diaspora, we're thinking both males and females, so we can form those community bonds and extend them. So thank you. Dr. Garvey, we return to you again. And if you would be so kind as to participate in the panel. Your comments and thoughts and framing enable the panel to get started, but you also are a part of the panel.
Well, we have to return to who we were, to understand who we are, and also to chart the course for where we want to go. And I appreciate Eric, I'm calling you Eric, I hope you don't mind. I congratulate you on your achievements. I don't know the depths of them, but I'd love to investigate that at some time and get to know you, because you obviously have a very strong character and persona, and you're an achiever. I think to get that level of self-understanding is a process. And Eric measures himself against a certain standard that has been set by the white community, and then he exceeds it. And that's great. That's how you break records every day. And he, you know, maybe I go back to Jack Johnson as opposed to Jesse Owens, because I'm a little bit older than you. Although I wasn't necessarily around with Jack Johnson, but certainly Joe Louis. And I used to listen on my radio back there in Jamaica as Joe Louis was beating them up. and I enjoyed that tremendously, because, you know, it was breaking the bar and it was upsetting the apple cart. For me, it's a very, very personal story in that it is an internal story as opposed to the external bar at which you're measuring yourself. In other words, perhaps I grew up in a household where, you know, my mother told me, you know, always that you have to be the best that you can be. It wasn't a matter of what standard somebody else set out there. So I was, in a sense, always competing against myself to be better and better and better and better. And that's just one way to do it. You know, I'm sure you've inculcated that as well, maybe from your parents, maybe just from your own understanding. But the bar in the long run has to be that internal one, because I think, you know, as Africans, we're children of God, but our God is not external. We have not outsourced our divinity. Our divinity is within ourselves. And the only way we can truly achieve is if we access the divinity that's in us. And again, if you go back to Kemet and you see the gods blowing breath into the little human being that was being fashioned out of clay, We know we're a spiritual people. I think one of our problems is that very much our religion has gone astray in that it has been contaminated over the years and so on and so forth by many, many misunderstandings. But we have to get back to our spiritual selves, because that's the only thing that cannot be broken. That's the thing that connects us to our source. We are divine beings. And when we access that, then nothing is impossible, because that's the totipotential source. And that's where you can always go for inspiration. That's where you can always go for guidance. And, you know, I am not a preacher, and I see Sharon Williams there smiling away and so on. And I don't see the face of Brother Noah, but he's probably smiling as well, because I'm intruding on their territory. But you see, I don't believe in religion separate from secular. I think, you know, all of life is sacred, and all of life is spiritual, and you have to manifest that which is in you, which is your spiritual component. That was your gift as a child. You're a child of God, and you have to manifest that. So ultimately, where you look is within yourself. And when you look within yourself, then you can break all those barriers that Eric talked about, you know, and again, Jesse Owens, Jack Johnson, you know, Joe Louis, and whatever, Martin Luther King, Malcolm X, and so on and so forth. All of those people, not that I know some of the earlier ones, but I certainly do know that Malcolm and Martin were spiritual. I know my dad was spiritual. You know, when he says, liberate your minds from mental slavery, that's what happens. When you liberate your mind, you access your spirit. So this is the key to our success going forward, is that we have to access our spiritual self. And again, we go back to that comment we talked about earlier, man, know thyself. This is, what you might call it, this is our gift from our ancestors. Man, know thyself, okay? Now, the Greeks tried to adopt it, but they lost because the Romans were very barbaric and they crushed it. And what we've gotten out of Europe is largely barbarism, you know, focused on the physicality of our senses and an intellect that is simply, you know, used to confuse people and to separate people into self and other, and individualism, which triumphs over the community. So that's a paradigm that we have to get away from, and have the paradigm of community and cooperation, and understanding that, you know, we're here as a gift from God, and we need to share that gift that we have and that we are in terms of our potential and our capacities with our community and with our nation and with the world. So to me, it's sort of a spiritual quest that I think we need to get back to, because that's who we always have been. And that's what has not been destroyed so far, but we are in danger of that destruction, because we're living in the belly of the beast, where there are no more morals, there are no more values, and all there is greed and competition. And certainly that's destroying the planet. And it's destroying us as African people living in the belly of the beast.
So clearly stated, Dr. Garvey. I know I need to turn this back to Mel shortly, but I did want to do two things. One, to ask any of our panelists if there was a comment or a thought that you'd like to offer in our forum. Is being Black bad for your health? Any panelists would like to take a minute or two? Yes, Eric.
Well, I'll just, and I appreciate the comments there. I'll just, again, in thinking about my own ethic, as I challenge myself, again, I agree with you, Dr. Garvey, that looking internally for those standards. I think some of the measures that, you know, I have on myself are universal, right? Doesn't matter if you're American, African. So education, service, love. I'm a Christian, so practicing my faith and how I live out my faith walk. So those are universal things in which I operate. I just happen to live in America, where I'm being judged by an American set of standards, right, as I move on. And so one of the things I'd just like to talk about in terms of, again, measuring myself and pushing myself, my company, NanoCan Technologies, we are developing some innovative therapeutics in the area of cancer, and working with who I believe is one of the most brilliant scientists in medicine, Dr. Will Inwa, professor up at Harvard, and one of the collaborators of this event. My company is funding some work with him. And part of our commitment in that project is that we are going to deploy the technology in Africa. We're going to establish operations. Dr. Garvey talked about manufacturing. We're going to set up manufacturing operations on the continent. My partner, Jock Walker, and I have both done work in Africa. Jock has done much more than me, but I helped to privatize South Africa's telecom system in 1996, right out my first year out of law school. And so we're going to go back. And again, that is, again, a measure, right, of what I can do to contribute to change the narrative of Africans dying from cancer, which many of them do, and treatable, some of which are treatable cancers, and all the other health disparities that exist. And so I just wanted to just put that out there, just about our company, the work we're doing with Harvard, and some other leading academic institutions are involved in our projects, but changing the narrative in that way and executing on bringing real concrete and measurable solutions to our people.
Most appreciated, Eric. Timeliness of the standards and the commitments.
I just want to say thank you for that, and I agree with everything you said, and I look forward also to meeting you and working with you in that area. Thanks for your comments and your presentation.
Yes. Okay. We're coming up on 12 noon, excuse me. And so I want to thank the panel for the engagement with us today, the insights. If you've been following the Zoom group chat, we were not able to get to some of those comments, but I want to say on behalf of the Ronald H. Brown African Affairs Series, CFA, Harvard, and the Johns Hopkins Center for Africana Studies, thank you for allowing me to be the moderator of the panel. And so I'm going to turn it back to Mel.
Thank you very much. What a wonderful panel. I mean, wow, this is the conclusion of the 2020 Ronald H. Brown African Affairs Series. Kelvin Johnson, I want to throw you a touchdown now. I still don't know why you retired like that, but you had your reasons, you know, and Detroit hasn't been the same since, you know. I had to get that in there. But this has been an absolutely awesome panel. We are gonna, the panel has been recorded, so we're gonna post the video, and we're gonna share it in a way of the network. It was always great to work with Harvard University and Johns Hopkins. You know, we've been having conversations prior to this. This is just the beginning. You know, we're gonna solidify this and really, you know, we have direct contact with the Africa Center for Disease Control. John Nkengasong was awesome, awesome. Congresswoman Karen Bass, who's a good friend, is awesome, you know? So the power that was on this call today is absolutely astounding. We're going to do everything possible to share it, to make sure the diaspora is aware of, you know, what's going on in Africa, especially in the health space. There's much more to do. So I just really want to say thank you all for, now my chairperson, Janine Scott, is going to say a few things. I had to make sure she says something, but I like to keep my job. So I'm going to pass the ball to Janine Scott, who's going to close us out. Janine.
Good morning, or going into afternoon, I guess, for everybody now, maybe evening even for a few. This has been truly, truly an outstanding discussion this morning. And I'd like to, again, thank Will for all of his support, the people at Harvard, Dr. Nkengasong, all the other speakers who joined with us this morning, shared their wisdom. And, you know, I'm sure, as Mel always tells you in the beginning, that the role of CFA is to educate. We want to educate people about issues that are of importance to the African continent and her diaspora, and how we are in position to interface for transformation, especially on the continent of Africa. So I'm hoping that not only were we educated on some very important issues of the day, but that we are also called again to action, because education is fine, but I know that we also want to be catalyzed to move. And as Mel said, this is not the end, this is the beginning. CFA has had a working group on health and health infrastructure issues, and I think that it's incumbent upon us to galvanize what we've had here this morning and to continue to move forward with this discussion, but also in terms of looking at how we may play a role and bring the diaspora to the forefront of playing a role in taking some definitive actions, whether it be in policy, whether it be in mobilizing people for certain types of investments, transformative healthcare solutions, investments in the private sector in PPE, excuse me, or drug manufacturing and the like. Those are areas, I think, with the renaissance that we see of African peoples, particularly in the diaspora, looking back to the continent, those are areas that we can explore where we may be able to do more and take the education that we've gotten this morning and that we continue to update ourselves on and turn it into some active and proactive and positive interventions for the continent. With that, I thank everyone for your participation this morning, and thank you all who participated in the entire series this year. It's been a learning experience for us to do it online, but I think it's also been very good. We've been able to reach so many, so thank you again.
Thank you, Janine. And if I may, we're going to have the Africa Business Conference, second one at Johns Hopkins on March 6, 2021. We look forward to working together and partnering.
Eric, we want to all talk to you. You laid out some very heavy stuff there. And we had a lot of people on the call yesterday on the trade piece. We want to make sure you connect with them. I see all kinds of areas of collaboration and cooperation.
Yeah, I think you're good friends with Jock Walker and Dr. Inwan. So you can I talk to them both frequently. So
me too, every day.
Every day, yeah.
Yeah. This is great. This is just awesome a conversation. Somehow I don't feel that all the conferences I see, in the case of CFA, there have not been one white person speaking the whole week. Not one. Can you imagine that? And we're talking about trade, we're talking about healthcare, we're talking about all the critical issues concerning Africa from an African perspective. African Americans, yesterday on the trade panel, all the speakers were African Americans who lived in Africa. They moved to Africa. They're doing business in Africa. They're making money in Africa. They're doing a lot. Whoa, when was the last time we had a conversation like that where Africans are talking to African Americans, straight up as brothers and sisters? So we think this is where we're going, and we're not apologizing for it. We welcome anybody to listen in, but we wanted to really, we had a conversation with Black Peace Corps volunteers. I'm a former Peace Corps volunteer. And we had a conversation of Black Peace Corps volunteers. What do we think? All the volunteers worldwide have been evacuated because of COVID-19. So now they're trying to figure out how do we go back. Well, we want to have a say in that. We want to have a say in the policy. We want to have a say in your recruitment. We want to have a say in, wow. And I can say the Peace Corps was listening with attentive ears, and we're confident of a follow-up. So, my message has always been, don't agonize, organize. And that's where we come from. Let's organize. I don't care about all the problems we got, but let's organize and see what we can do to actually change the paradigm. I should get a PhD from Harvard for this. Will? Yeah, give me a PhD. Yeah. Thank you all for joining us. And we will stay in touch and we will follow up.
Thank you for the leadership always.
Thanks. Thanks, everyone.
Thank you, everyone. Thank you. Bye-bye.
Thank you, everybody.